Hello, I'm Joseph Schulman, and I'll be speaking to you about practice variation with regard to antibiotic use in the NICU. I have no financial relationships to disclose that are relevant, and my goal is to describe the range of variation in NICU antibiotic prescribing and highlight the impact of unwarranted variation. This stems from work done by California Children's Services, also known as CCS, which confers state approval for 3 levels of NICU care, regional, community, and intermediate, roughly corresponding to American Academy of Pediatrics levels 4, 3, and 2, respectively. Beginning in 2013, CCS required approved NICUs to report their annual antibiotic use rate, or AUR. The study data set approximates a population-based database describing NICU care and outcomes for most of the more than 500,000 live births in California in the year 2013. This slide graphically shows the range of variation in antibiotic use rate overall in the state, as well as stratified by level of care. There were 127 NICUs that contributed to the analytic data set, reflecting care for more than 52,000 infants, almost 750,000 patient days, of which about 214,000 involve antibiotic exposure. As you see in the box plot, antibiotic use varied very widely. Quantitatively, it was 40-fold variation from a low of 2.4% of patient days to a high of 97% of patient days, with a median of 24.5%. The smoothed curves that are either solid or dotted show the distribution of antibiotic use rate according to level of care. What's striking in this particular slide is that regardless of the level of care, there is a similar pattern in distribution of antibiotic use rate. We found that there was no correlation between antibiotic use rate and proven burden of infection, rate of necrotizing enterocolitis, surgical case volume, or NICU mortality. Nor was there a difference between NICUs in the lowest and the highest quartile of antibiotic use rate for these same outcomes. So NICUs appear to differ only in their rates of suspected infection. That is, practice variation in antibiotic use appears to hinge on how practitioners frame, interpret, and respond to clinical situations that ultimately are considered unproven infection. Therefore, there is unwarranted variation in antibiotic use, and indeed, in some NICUs, antibiotics are overused. This matters because antibiotic use impacts the separation of mother and baby. It impacts the development of antimicrobial resistance, and infants treated with antibiotics experience a decrease in the genetic diversity of their microbiome. Additionally, we know that the majority of very low birth weight infants are exposed to antibiotics. To confirm your understanding of the takeaway message, I provide the following test question. The evidence describing antibiotic use across NICUs indicates that, and the correct answer here, of course, is choice number 3, extremely wide variation in antibiotic use exists across NICUs and is unrelated to the burden of proven infection. Thank you for your attention.